Good afternoon, everyone. I'm Shobit, a final year medical student at Armed Forces Medical College, Pune. I'll be moderating this session along with Zara, who is a postdoctoral research fellow at Stanford. Thank you for joining us. Let's get started. Over to you, Zara.
Good afternoon, everyone. I'm Zara Shokri, a medical doctor and postdoctoral researcher at Stanford University. I'll be moderating today's session along with Shobit. And thank you so much, Dr. Deng, for joining us today. I have the great pleasure of introducing Dr. Deng. Dr. Deng is an assistant professor of radiology and radiological sciences and co-director of diagnostic radiology medical student electives at Johns Hopkins University. He was voted Faculty Educator of the Year by Hopkins Radiology Residents in 2023 and was the finalist for Mini's Most Effective Radiology Educator Award in 2024. He is also an editor at Radiopedia and has authored chapters on brain, head and neck, and spine in the Core Radiology second edition. It's truly an honor to have Dr. Deng, and thank you so much for volunteering your time to present some fascinating cases. Welcome, Dr. Deng. Over to Shobit to introduce the session to you.
Okay, so we'll be having a poll kind of format today. So, Dr. Deng, if you could start your screen sharing with us, let's start the session.
All right, so thank you, Sarah and Shobit, for the introduction. Welcome, everyone. I can think of nothing better to do on a Saturday afternoon than learn head and neck radiology. So if you would please log into pollev.com/nrad. This will be a competition style. You can choose your anonymous or real name handle to participate in the competition. And after each question, there will be a leaderboard just to win internet points to see who is getting the right answer and who's getting the right answer fastest. So we're going to have 33 questions over the course of this review session, all focused on head and neck radiology with an eye towards those topics that would be high yield for the boards. So without further ado, let's get started. So our first case is going to be an 80-year-old with headache. What is the likely diagnosis? You'll have 30 seconds for each question, after which I'll review the answer. Okay, and the vast majority got the answer correct, which is pituitary apoplexy. So the main finding in this is a hyperdensity in the suprasellar region, and that would make a hemorrhage into the pituitary gland, likely to an underlying macroadenoma or microadenoma potentially, the cause of this patient's headache. Some of you chose the distractor aneurysmal subarachnoid hemorrhage. However, that would fill the subarachnoid cisterns more confluently than this. This is very localized. While this could be a suprasellar kind of aneurysm from some branch of the ICA, it does not appear on this image that there's any evidence of subarachnoid hemorrhage, so that is not the correct answer. All right, so we have a four-way tie for first coming out here. And I noticed that there are only about 30-some participants, but there are more than 80 in the call. So if you did not get a chance to log in yet, go to pollev.com/nrad. The next question is for a 75-year-old with headache. What is the diagnosis? The correct answer is aneurysm here. What we see here on the T2 weighted image is a structure in the suprasellar region that has a peripheral band of hypointensity and a kind of a gradient of hyperintensity. In our coronal T1 post-contrast image, we again see internal hyperintensity or contrast enhancement, but a gradient kind of effect. This appearance is that would be typical for an aneurysm. You can also see some of this pulsation artifact reverberating in the horizontal kind of plane here on this coronal image that would further support that this thing is very pulsatile and creating these pulsation artifacts. So the correct answer is aneurysm here, and this turned out to be an aneurysm off of the right ICA on subsequent CT angiography. We have a two-way tie for first with D and guess 425. So the poll everywhere link is pollev.com/nrad. It's at the top of each leaderboard slide. The next case is a 90-year-old with a fall. What is the diagnosis? So the correct answer here is osteolipoma, which a plurality chose. What we see on this sagittal CT image is a calcific density lesion along with fat density lesion in the region of the suprasellar cistern to interpeduncular cistern. And this is a location in which you can get intracranial lipomas. Intracranial lipomas are most commonly located in the midline, either in the pericallosal cistern, the quadrigeminal cistern, or the suprasellar cistern. And this turns out to be a rare variant of a lipoma that is partially ossified, and so it's called an osteolipoma. Now, the reason it's not a craniopharyngioma is it doesn't have bulk fat. It's not a perimesencephalic subarachnoid hemorrhage because this is ossific and fat density, and you don't really see that with subarachnoid hemorrhage, which would be more like 80 pounds per units, and not this, which is like pineal calcification density. So that's not the right answer either. And it's not meningioma because it's not really based at the dura here. There's a separation between this lesion, which is in the suprasellar cistern, and the dorsum sellae. So we have some separation on the leaderboard now. And if you just joined us, you can go to pollev.com/nrad for participating in the competition. Our next case is a 20-year-old with headache, fever, sinus pressure, who is unable to raise their eyelid and right eye is dilated. What is the diagnosis? Okay, and the correct answer here is venous sinus thrombosis. So what we have here are coronal T2 weighted and coronal T1 post-contrast images through the cavernous sinus. And what we see is an abnormal contour to the cavernous sinus. These are bulging outward, whereas a normal cavernous sinus would have a concave kind of outer contour. And in addition, on the T1 post-contrast image, you see filling defects. So normally cavernous sinus would homogeneously enhance with contrast, whereas there are these filling defects here on the right and on the left as well. What is causing the patient's symptoms? Well, it's compression from the thrombus on the third cranial nerve, which is located in the superlateral quadrant of the cavernous sinus, seen on a coronal image. And so this blurry black thing would be the right oculomotor nerve, and this is the one on the left, and these are being kind of displaced and compressed against the dura by this thrombus. So this is venous sinus thrombosis. Why is the answer not Tolosa-Hunt syndrome, which half of you chose? So Tolosa-Hunt syndrome would be a granulomatous inflammation of the cavernous sinuses, which would appear as bulging, but also kind of more homogeneous contrast enhancement of the cavernous sinuses, and you may see contrast enhancement of the cranial nerves as well, but it would not explain these filling defects. So this one turned out to be a case of sinusitis that was complicated by cavernous sinus thrombosis, and bloodstream cultures grew out Fusobacterium necrophorum. And this was the thrombus was extending through the inferior pectoral sinuses into the jugular veins, and that was consistent with Lemire syndrome. Next case is a 70-year-old with left pulsatile tinnitus. What is the diagnosis? The correct answer that nearly everyone chose was dural arteriovenous fistula. What we see here is a time of flight angiogram and a maximal intensity projection. And on this image, you should only see arteries, but instead there's abnormal flow-related enhancement in the left cavernous sinus. That's this blobby thing right here next to the cavernous internal carotid artery. And in addition, you see flow-related enhancement in the left superior ophthalmic vein, which is over here, coursing into the orbit over here. And as well, there's some asymmetric, prominent vessels in this region. These are additional veins into which there's reflux of blood flow. And so this is lighting up on the time of flight MR angiography. And so this represents a cavernous, carotid cavernous fistula, or CC fistula, which is a special subtype of a dural arteriovenous fistula. This can be direct, i.e. through a rent in the cavernous internal carotid artery dumping right into the cavernous sinus, or more commonly an indirect CC fistula, which would be either branches of the ICA, ECA, and or both that connect into tributaries of the cavernous sinus. And so the MR imaging abnormalities that are seen with the CC fistula are, you can see flow-related enhancement in the cavernous sinus, you can see distension of the venous structures, such as the superior ophthalmic vein, and you can see engorgement of orbital structures like the extraocular muscles, resulting in proptosis, but I didn't show those images in this case. When you see this appearance on time of flight MR angiography, this is nearly pathognomonic for a carotid cavernous fistula, and this was subsequently confirmed on a digital subtraction angiography. All right, we have radius at number 1 here. The next question is a 35-year-old with headache. What is the diagnosis? The vast majority of you chose the correct answer, which is epidermoid cyst. So we have 4 MR images here. That is a T2 weighted image, T2 flare, DWI, and a T1 post contrast. What we see is a diffusion restricting material in the right cerebellopontine angle cistern extending into Meckel's cave. This is nearly CSF, signal intensity on T2, and does suppress signal on flare as well, but we know there's an abnormality there because it's very bright on DWI, and it's not contrast enhancing, so it's not like a solid vascularized mass. And this appearance of a diffusion restricting extraaxial CP angle lesion is pathognomonic for an epidermoid cyst, which is an abnormal inclusion of epidermal elements, creating basically keratin debris that collects in the subarachnoid cistern in that location. Next question is a 55-year-old with asymmetric sensory neural hearing loss. What is the likely diagnosis? Now, most of you fell for my trick here and chose the incorrect answer of NF2-related schwannomatosis. The correct answer is metastatic disease. Most of you probably noticed that there is an enhancing lesion in the right internal auditory canal. Some of you may have also noticed that there are two small enhancing foci in the left internal auditory canal as well. But to get the right answer, you would also have to notice that there are additional enhancing lesions in the cerebellum, such as here, corresponding to a T2 hyperintense lesion that's partially contrast enhancing in the left cerebellar hemisphere. And there's also other tiny foci of contrast enhancement elsewhere that have a T2 correlate, so you know that they're not pulsation artifacts on the right as well. So this is multifocal leptomeningeal metastatic disease, as well as cerebellar metastases. Some of you have also may have noticed a very irregular contrast enhancing appearance to the clivus here with thickening of the retroclival dura. This represents osseous metastasis with epidural extension. So NF2-related schwannomatosis, the appearance of that would be bilateral vestibular schwannomas, which would appear as contrast-enhancing lesions in the internal auditory canal. And you may also have meningiomas, but you would not have these brain parenchymal or osseous findings. So radius still up at number 1 here. The next question is a 60-year-old with right ear infection. What is the best diagnosis? The correct answer that a plurality of you chose is necrotizing otitis externa. This is a very important diagnosis to identify radiographically, or radiologically rather. What we have is a temporal bone CT in bone kernel and coronal images and axial images. And the key finding here is recognize that there is bone erosion. So I told you that there was a right ear infection, and the key task for you to determine what kind of ear infection is this: otitis externa, is it mastoiditis, otitis media, or something else. And what we have here is erosion of the bone of the external auditory canal. So this is called a tympanic plate. You can see on the left side that's normal, that how it's smooth and continuous, and it goes all the way out to the junction of the bony and cartilaginous EAC. But there's erosion of the lateral, basically half of that bony EAC. Here you can see on the coronal image as well, the floor of the EAC is eroded as well. And if you really look closely, you may notice other places where there's osseous demineralization. So notice on the left side, there's a smooth, continuous bony cortex, whereas here on the right side, adjacent to the opening for the internal carotid artery, there's some demineralization of that cortex of the inferior surface of the petrous temporal bone. So all these findings are supportive of necrotizing otitis externa, also known as malignant otitis externa, with skull-base osteomyelitis. And so this is important to recognize because this is treated with IV anti-pseudomonal antibodies, whereas if you were to diagnose the patient with coalescent mastoiditis or otitis media, acute otitis media, that would be treated surgically with, cortical mastoidectomy or with antibiotics that are not necessarily directed against Pseudomonas. The entity of otitis media with effusion is actually a clinical term to indicate non-infected otitis media, meaning there's a serous effusion in the middle ear cavity, but it's not infected. So this would not be the correct answer. All right, we have Radius, Lennon, and Guest at 1, 2, and 3 here. The next question is a 50-year-old with mixed hearing loss. What is the diagnosis? All right, we have plurality choosing the correct answer, which is otosclerosis, and some people chose incutomalleolar dissociation and labyrinthitis. ossificans and perilymphatic fistula. The key finding here is on this temporal bone CT, you have a lucency of the bone of the otic capsule located immediately anterior to the oval window. This is the typical location of fenestral otosclerosis, the other type being retrofenestral or cochlear otosclerosis, that would be around the cochlea. So in cases where you have any conductive hearing loss on a temporal bone CT, always remember to look at the bone anterior to the oval window. This is in the region of the embryologic structure, the fistula antifenestrum, although the pathophysiology of otosclerosis has nothing to do with the fistula antifenestrum. It is just happens to be in this location. And so how does this cause conductive hearing loss? Well, there's bony overgrowth of this kind of spongiotic bone that causes fixation of the stapes footplate, preventing it from vibrating and transmitting the sound information. So this lucency anterior to the oval window is nearly diagnostic of otosclerosis. Now, in this case, I'm not showing you any separation between the incus and the malleus, so the distractor of incutomalleolar dissociation is not correct. Next question is a 40-year-old with left pulsatile tinnitus and ear mass. What is the likely diagnosis? I'm showing you coronal images through the temporal bones, non-contrast in bone kernel, arterial phase, and venous phase. Majority you chose the correct answer, which is paraganglioma. What we see here is a lesion in the jugular foramen that is permeating itself through the bone of the temporal bone. Okay, you see the normal density of the right temporal bone, the jugular plate, and so forth, and how this has a more moth-eaten appearance and a lower in density, and it's extruding onto the other side of the bone, which is at the medial part of the external auditory canal. And what are the other characteristics? Well, it is contrast enhancing on the arterial phase and seems to wash out just a little bit on the venous phase. Notice the higher density here and slightly lower density on the venous phase here. So this would be typical of a paraganglioma. So when you have a jugular foramen mass, you think about your main differentials of primary tumors of the jugular foramen being paraganglioma, meningioma, and schwannoma. And these have different effects on the surrounding bone. A paraganglioma causes a moth-eaten permeative appearance of surrounding bone. A schwannoma causes smooth bony remodeling, and a meningioma causes hyperostosis. So you can nearly make the diagnosis based on non-contrast images alone, but then additional factors going for paraganglioma is that it does enhance on the arterial phase and it starts to wash out, kind of in keeping with the hypervascularity of this tumor that's not typical of schwannoma. Although meningioma may also have this appearance, meningiomas tend to have more persistent enhancement profile, however. The next case is a 75-year-old with left pulsatile tinnitus. What is the likely diagnosis? I'm showing you serial cuts on a CT angiogram performed for the evaluation of pulsatile tinnitus. I'm telling you the abnormality is on the left. A plurality of you got the correct answer, which is dural arteriovenous fistula. So the key imaging findings to notice here is that this is a CT angiogram arterial phase. You can see the internal carotid and vertebral arteries quite well. But in terms of the venous structures, there is an asymmetric contrast enhancement of the left the sigmoid sinus and the jugular bulb here. And that is, in the correct clinical setting, potentially due to a dural arteriovenous fistula. Now we can look for other more subtle signs of dural arteriovenous fistula to kind of corroborate our suspicion. Number one, there's this linear filling defect within the sigmoid sinus, and this may be due to chronic thrombosis. So dural AVFs are associated with chronic thrombosis of the venous sinus, and that may be either a cause or sequelae of the dural arteriovenous fistula. It's a common association that after you get a dural venous sinus thrombosis, that you develop some recruitment of arterial feeders, and that creates a dural AVF. And it's also true that dural AVFs, because they dump arterial blood into the venous sinuses, that causes endothelial damage, and that may promote the formation of thrombosis. In addition, at the lower level, we can see there is some hypertrophy of external carotid artery branches. So you can see here, this is the occipital artery, which courses behind the mastoid, and you can see it's larger than the contralateral side. This dot right here is the middle meningeal artery, which supplies the dura of the middle cranial fossa and so forth. And this is hypertrophied relative to the right side. And one final dot is this one. This is the ascending pharyngeal artery, which is another branch of the ECA that supplies the dura in the jugular frame and posterior fossa region. So all of these are hypertrophy, which is another feature of dural arterial venous fistula. You got hypertrophy of the feeding arteries. You have early arterial, kind of phase contrast enhancement of venous structures, and you get thrombosis of the dural venous sinuses. Our next case is a 90-year-old with adenoid cystic carcinoma. Perineural tumor spread along what nerve is indicated on these images? I'm showing you T1 post-contrast coronal image and a corresponding CT image, just to help you get your bearings about the anatomy. But it's not that the CT shows perineural tumor spread, it's shown on the MRI. So this is a pretty straightforward anatomy question, meaning what is the foramen that is indicated by the arrows and what nerve goes through it. So the foramen that is indicated is the foramen rotundum. You can remember that because on a coronal image, it has a round appearance, i.e. The term rotundum is according to its appearance on a coronal slice. And that carries cranial nerve V2, which is the maxillary nerve. The other holes that you can identify on coronal images through the sphenoid are this one, which is the optic canal carrying cranial nerve 2, the optic nerves. This ovoid area is the superior orbital fissure, which carries cranial nerve 3, 4, V1, and 6. This one, again, foramen rotundum, carries maxillary nerve or cranial nerve V2. And then this one here, more medially, is the Vidian canal, which carries the Vidian nerve. All right, we have a new leader on the board, RADFADS. 40-year-old with trigeminal neuralgia. What is the likely pathology for the structure indicated? I'm showing you KISS axial, sagittal, T1 post-contrast axial, and ADC map axial image. If you have any questions as we go along, feel free to post in the chat, and I think our hosts can help me monitor that. So the correct answer here is a notochordal proliferation, specifically the entity known as echordosis physolifera. Now, only about 28% of you chose the correct answer here. So let me go through the imaging findings. On the KISS sequence, we see a lobular T2 hyperintense lesion in the prepontine cistern emanating from the dorsal clival surface. And here it is on the sagittal image. And on the T1 post-contrast image, we see no contrast enhancement whatsoever, but we know there's a lesion there based on its appearance on the KISS image. And there's this like thin rim of a thickened membrane. And on the ADC axial image, we see that this is relatively bright on ADC, so facilitated diffusion relative to brain tissue as an internal reference. Now, there aren't too many lesions here in the prepontine cistern that is essentially not contrast enhancing and very high signal intensity and facilitated diffusion, the most prototypical of which are notochordal remnants, the benign version of which is called echordosis physolifera, and the malignant version of which is chordoma. Now, some of you chose fluid and arachnoid cells, so that would indicate a arachnoid cyst, but the arachnoid cyst would have ADC that is closer to that of free-flowing CSF, and you would not see this kind of dirty signal inside, and you would not see this kind of thick membrane at the surface. Some of you chose keratin debris. So keratin debris would be an epidermoid cyst, and that would be far darker on an ADC because remember, the typical imaging appearance of an epidermoid cyst is that it restricts diffusion, and this ADC does not really indicate that this is really would be bright on a DWI trace image. So the correct answer here is a notochordal proliferation. In this case was actually biopsy proven because even though these are typically no-touch lesions, the equinosis physolifera is a no-touch lesion. This patient was undergoing neurosurgery for microvascular decompression of their trigeminal nerve, and because they were in the vicinity, they saw this as they were decompressing the left trigeminal nerve. They decided to take a piece, and so this was path proven. A 35-year-old with epilepsy is our next case. What is the diagnosis? The correct answer was chosen by a majority of you. 69% chose encephalocele. So what we see on the CT image is a defect in the wall of the sphenoid sinus near the pterygoid recess. Here's the start of the pterygoid plates, and so this is called the pterygoid recess. So there's a defect, and there's an opacification in that pterygoid recess of the sphenoid sinus. And what does that opacification represent? Well, we see on the T2 weighted image in a PSIR, which is a phase-sensitive inversion recovery, that's kind of a T1 weighted image, we see that this is essentially a protrusion of the part of the temporal lobe that is nearby into that that defect. So this is a meningoencephalocele, or more simply described as a cephalocele or an encephalocele. And that is causing some high signal abnormality on the T2 weighted images here for that cortex, but that does not necessarily mean that this is focal cortical dysplasia, which was a distractor that some of you chose. So this encephalocele causes irritation of that brain and causes edema and gliosis in the adjacent brain. That is involved. And so it may mimic the appearance of a focal cortical dysplasia, but the key to getting the right answer here is noticing the contour defect through which brain is abnormally herniating through. So that's an encephalocele. A 40-year-old with diplopia, what is the most likely diagnosis? Okay, a majority of you got the correct answer, which is chondrosarcoma. So on the images, we see a very T2 hyperintense lesion located at the left petroclival synchondrosis. This is not that very enhancing on T1 post-contrast images, although this entity, some of it does enhance with contrast. On the CT images, we see a mostly lytic abnormality, but there are some areas of bone formation or displacement by this osteolytic abnormality. And on the ADC map, this is very high diffusivity relative to brain. So in this location, the petroclival junction, a T2 hyperintense expansile lesion with maybe some calcification and high diffusivity would be typical of a chondrosarcoma. Some of you chose cholesterol granuloma, so that would be T1 hyperintense located at the petrous apex. It would be expansile like this, but on the T1 post-contrast image, we did not see any hyperintensity, either intrinsic or contrast enhancing. And so cholesterol granuloma would not be the correct answer. Cholesteatoma would restrict diffusion because a cholesteatoma is basically an epidermoid cyst located within the temporal bone. But again, because of this facility diffusivity on the ADC map, that would not be the correct answer. So that case was chondrosarcoma, and that was path proven. Our next case is a 60-year-old with right eye pain and swelling. What is the likely diagnosis? So I'm showing you T1 post-contrast coronal image, T1 axial post-contrast, T2 fat-suppressed axial image, and an ADC map through the level of the paranasal sinuses and orbits. Okay, so the correct answer here is lymphoma, which only a minority of you chose as the answer. Let me go through the imaging findings. So there's confluent contrast enhancing abnormality throughout bilateral nasal cavities, ethmoid sinuses, extending into the anterior cranial fossa through the cruciform plate, as well as into the right orbit, especially, but perhaps a little bit of the left as well. So we have the sense of a very infiltrative abnormality that is confluently contrast enhancing, so very hypervascular or well vascularized. And we can see that on the axial images as well, that is extending into the premaxillary soft tissues here. This lesion is T2 bright. And in addition, we also notice that there are some enlarged nodules here in the right parotid and the right retropharyngeal station that represents enlarged lymph nodes, left retropharyngeal station as well. And on the ADC map, we see that these lesions are quite dark. So these restrict diffusion. So this is a hypercellular abnormality of kind of like the lymph nodes as well. So when you see confluent contrast enhancing lesion infiltrative in the sinonasal cavity and orbits, as well as lymphadenopathy and it's diffusion restricting, that is typical of lymphoma. Why is it not acute invasive fungal sinusitis, as 67% of you chose? So acute invasive fungal sinusitis causes basically ischemic necrosis of nasal mucosa because fungal elements are invading into the vasculature and causing necrosis of normal sinus kind of contents. And so you would not see large areas of homogeneous contrast enhancement like this. You would see areas that are not quite as thick, and they would be hypoenhancing on post-contrast images. And while you may have kind of infiltration of the premaxillary tissues and of the orbits and so forth, it would not be so mass-like like this case of lymphoma was. So this turned out to be a diffuse large B-cell lymphoma. Our next case is an 85-year-old with blurred vision in the left eye. What is the diagnosis? %98 of you got the correct answer, which is lens dislocation. This patient has bilateral intraocular lens replacements, which appears on T2 weighted images as a linear thing in the location of the usual native lens. But this one is dislocated posteriorly into the posterior aspect of the globe. And it doesn't have any particular findings on the T1 post-contrast image other than maybe a little bit of a low signal intensity artifact here. But this is the key finding, and nearly all of you got the correct answer, so I won't belabor it. So RADFADS is still up at #1 on the leaderboard. Our next case is a 40-year-old with right eye injury. What is the substance indicated by the arrows? So we have an axial CT image without contrast, a sagittal T1 weighted image without contrast, a T2 fat suppressed image, and a T1 post-contrast fat-suppressed image. Okay, the correct answer is silicone. So what we have is a hyperdensity in the right orbital intracoronal space retrobulbar, and it has the same density as this material within the globe, which is quite dense as well, and that is consistent with extruded silicone. This patient had an open globe injury, and the silicone that they had in their eye that was being used to tamponade a prior retinal detachment. You can also see a scleral band here used for helping treat the retinal detachment. That has somehow extruded from the eye and landed in the retrobulbar intraconal space. And what happens with silicone on MRI? So it creates this chemical shift artifact around. The center part of it is a little bit hyper intense on T1, but then there's this chemical shift artifact around it in the globe, as well as this extruded portion. And on fat suppressed imaging, because the um, signal characteristics, the kind of inversion time, or the kind of the chemical shift properties of the silicone is kind of close to fat. And if you don't do like a very super selective suppression, you're going to suppress the signal from silicone as well. You can see the dark stuff in the globe, and it is also suppressing the extraocular stuff. You can see that on this fat suppressed T1 weighted image just as well. So this is extruded silicone from an open globe injury. And that's not to be confused with hemorrhage, which would also be hyperdense, but would not create these chemical shift artifacts, or nor would it suppress on fat suppressed imaging. A 17-year-old with right eye injury is the next patient. What is the diagnosis? The majority of you got the correct answer, which is trapdoor fracture. So the imaging findings are there's a non-displaced fracture of the orbital floor. You can see it minimally displaced on the sagittal image, but the coronal images that I showed were at a location that was minimally displaced. But below this minimally displaced orbital floor fracture, there is fat density, which is orbital fat that has gone through that fracture defect. And so what trapdoor fractures are they are orbital floor fractures that swing open transiently, part of the orbital contents herniates through, and then the fracture springs back in its normal position because of the springiness of bone, especially in younger patients, adolescents, and young adults. And that creates an incarceration of orbital contents below the fracture, and that can be a cause of extraocular motility limitation, which this patient had. It could be that part of the muscle is there, or just septae to which the muscle is attached are herniated through this trapdoor fracture. And so it's important to recognize that this exists, and not to miss that there is a fracture, and that needs to be correlated clinically with exam as to whether they have any motility limitation, because if they did, then that would be an indication for repair, even though that this is not significantly displaced. Next case is a 25-year-old woman with headache and vision changes. What additional intracranial imaging finding is most likely present? I'm showing you a bunch of MR images through the orbits only. I'm asking you what intracranial imaging finding might be present in this individual. Okay, great. Majority of you got the correct answer, which is transverse sinus stenosis. So the orbital imaging findings are punctate hyperintensity on the DWI at the optic disc, also known as the optic nerve head or the optic papilla. And this corresponds to contrast enhancement of the optic papilla that is protruding into the eyeball. And on the T2 weighted images, you can see subtle flattening of the posterior globe surface. So these are all findings that are the radiologic version of papilledema or optic disc edema. And that would be manifest on a fundoscopic exam as papilledema, or they describe it as optic disc edema. And optic disc edema that is bilateral is most commonly due to intracranial pressure increase. So that would be called papilledema. And so of these findings, which one is associated with intracranial hypertension? Well, it's transverse sinus stenosis. So bilateral high-grade transverse sinus stenosis is well correlated with idiopathic intracranial hypertension. And that occurs in kind of reproductive age women with headache, vision change, and or pulsatile tinnitus, especially those who are overweight or obese. The second most common answer that people chose was pituitary engorgement. So pituitary engorgement is a sign of intracranial hypotension. Intracranial hypotension, spontaneous intracranial hypotension due to spinal CSF leaks, would cause pituitary engorgement, but they would not cause the orbital findings that we see here of optic disc edema, distension of the optic nerve sheaths, posterior globe flattening, and so forth. Those are signs of intracranial hypertension. And it is not demyelinating plaques because this is not the appearance of multiple sclerosis related optic neuritis. So that would be evident as contrast enhancement of the intraorbital optic nerves, not necessarily the optic nerve head. And it would more often be unilateral and not bilateral. And it wouldn't cause the optic nerve sheath distension. Our next case is a 25-year-old with headache and 6 months of nasal congestion. What is the most likely diagnosis? I'm showing you axial CT images in soft tissue kernel and bone kernel, as well as MRI, T1 post contrast, and T2 fat suppressed images. Okay, great. We have a majority here choosing allergic fungal rhinosinusitis, which is the correct answer. On CT in this entity, we see hyperdense opacification of the paranasal sinuses. In its severe form, we can have expansion of the bony walls of the paranasal sinuses and dehiscence of the wall as well due to the kind of constant pressure of this filling of the paranasal sinuses with this inspissated eosinophilic mucin with fungal colonization. And on MRI, those contents are, internally that are hyperdense on CT are not contrast enhancing because this is just eosinophilic debris and mucin and fungal elements. And characteristically, they have very dark signal on T2 weighted imaging because the fungal elements contain minerals that are paramagnetic and result in signal dropout on T2 weighted images. And so this is not to be mistaken for a neoplasm, which sometimes it is, because people are kind of scared by how aggressive looking it is on CT due to the bone dehiscences. But this is a classic appearance of allergic fungal rhinosinusitis. Next case is a 40-year-old, otherwise healthy patient with right post-ocular pain and a recent tooth infection. What is the most likely diagnosis? So I'm showing you an axial and a coronal CT post-contrast. Okay, the correct answer here is malignancy. And unfortunately, a majority you chose the incorrect answer of complicated bacterial sinusitis, which was actually in the real world, the original interpretation by an outside radiologist. In this case, the misleading context clues here were that they had a recent tooth infection, and so people were clued in to think about infection. But what we see here is that on post-contrast CT, that this is a contrast-enhancing lesion, and it's unilateral, centered in the right ethmoid sinus and protruding into the right extracoronal orbit due to dehiscence of the lamina papyracea that is quite wide. This is not the appearance of an acute bacterial sinusitis, which would involve multiple sinuses. The center would be filled with non-enhancing fluid, and while it can cause a subperiosteal abscess, it doesn't have this mass-like appearance protruding into the orbit. And so, once they were transferred to our institution for further evaluation by ophthalmology, we overread the study and concluded that this was likely to be a malignancy, which this turned out to be. It was actually some entity that you don't need to know, but it was called a nut carcinoma, NUT carcinoma, which is a high-grade undifferentiated carcinoma of midline structures like the sinonasal cavity and the mediastinum. Four-year-old with headache and optic disc edema. What is the finding indicated? Showing an axial CT bone kernel, sagittal T1 without contrast, axial T1 with contrast, and an axial T2 with fat suppression. Okay, the correct answer here is arrested pneumatization, which 38% of you, the plurality of you, did choose. Now, the classic appearance of arrested pneumatization of the skull base is occurring in the sphenoid, and it has the appearance of what would have been an aerated sphenoid sinus, but instead the center of it contains a mix of fibrous and fatty and osseous elements that just never pneumatized. And so it's different from fibrous dysplasia in that it's not like a homogeneously ground glass thing. It's not expansile, and it has fatty components, and it's it kind of has the appearance of bone marrow here, and these central kind of ossific components. It just never completed its pneumatization during development, but because of the kind of internal fat contents at the periphery and the kind of marrow appearance at the center, and the non-expansile heterogeneous appearance on the CT, this is typical of arrested pneumatization of the sphenoid, and a pathognomonic appearance. All right, so we have a new leader on the board. It's guest 871. The next case is a 55-year-old with headache. What finding is shown? So I'm showing you a coronal KISS sequence, a coronal T1 weighted image without contrast, and a coronal CT through the level of the orbits and anterior skull base. Okay, and the correct answer here is encephalocele. So most of you recognize, that 57% of you recognize that there's an abnormality here at the anterior skull base. This is looking at the fovea ethmoidalis, which is the ethmoid roof, and it has this T2 hyperintense appearance, and that represents basically an extension of the CSF space. This is a meningocele. And there's also kind of an abnormal appearance of the adjacent brain. That's because the brain kind of protruded into this defect and then became encephalomalacic and gliotic and has retracted. So there's kind of a widening of this fissure here adjacent to the gyrus rectus. And so there's probably a thin rim of kind of gliotic tissue here, but this represented an encephalocele through the anterior skull base in this patient who had a long history of idiopathic intracranial hypertension and also CSF rhinorrhea. Radius is back on the board. Our next case is a 20-year-old with epistaxis. What is the likely diagnosis? Okay, 90% got the correct answer, which is nasopharyngeal angiofibroma. So the typical vignette that you'll get in these cases is a young adult or adolescent male who presents with epistaxis. And the typical imaging features for this entity are a very well vascularized mass. Sometimes you can see flow voids within the mass. So you can see the, if you look closely, these dark dots here represent flow voids within the mass. You can see them on the T1 post-contrast image as well. And this is otherwise homogeneously contrast enhancing because it's very well vascularized. And it's located in the posterior nasal cavity and extending into the nasopharynx, and very characteristically extends into the pterygopalatine fossa through the sphenopalatine foramen and widens that space. So you have anterior deviation of the posterior wall of the maxillary sinus, and widening of this space is pretty typical of the growth pattern for this entity, which is also known as a JNA, or a juvenile nasopharyngeal angiofibroma. Our case was a 20-year-old, so on the kind of the tail end of the age distribution of this entity, but the imaging findings are pretty classic. So we have guest 871 back at rank 1. Shobit has put into the chat, please leave feedback for me and as well as for the moderators in Rad Discord. If you can click that link for a Google thing, and we just have a handful of cases left. But anytime you have free before the end of the session or after it, please click that link for feedback. So our next case is a 5-year-old with 5 days of fever and neck stiffness. What is the diagnosis? The correct answer here is subparative retropharyngeal lymphadenitis. The incorrect answer that 45% of you chose, as well as the outside radiologist chose in this case, was a peritonsillar abscess. The key to recognizing the correct answer here and the location of this is that on the axial image, this lesion is at the level of the nasopharynx and not at the level of the oropharynx. So we see nasal cavity here. We see, some folds that are kind of in the shape of the nasopharynx. And on the sagittal image, you can kind of confirm that you're very high up. You're not at the level of the oropharynx, which would be down here. You're at the level of the nasopharynx, which is kind of at the C1 vertebral level, and is very quite lateralized, and you don't see a rounded enhancing thing that would be the palatine tonsil at this level either. So this is the typical location of a suppurative retropharyngeal lymph node. So what this represents is a intranodal abscess that is surrounded by a nodal capsule in the retropharyngeal station. This is where you would look for retropharyngeal nodal metastases at the level of the nasopharynx at the kind of the C1 to upper C2 level. And is laterally deviating the kind of carotid sheath structures, and so that is the diagnosis here. Some people might call this a retropharyngeal abscess, but this is a slightly different entity in that this is localized with lateralized within the nodal station. So this represents suppurative lymphadenitis or an intranodal abscess in the retropharyngeal station. All right, so we have guest 871 still at number 1 here. The 65-year-old with right submandibular lump. What is the diagnosis? So the correct answer here is herniated sublingual gland. So what these images provide is that the right submandibular lesion is here, but has the same texture as salivary gland tissue, and it's distinct from the submandibular gland. And if you trace it, it's kind of contiguous with the stuff in the sublingual space. And so this represents a mylohyoid boutonniere deformity, which is a defect in the mylohyoid muscle sling through which sublingual gland has herniated inferiorly and outward through that defect. And so there's a mylohyoid boutonniere deformity and a sublingual bouton, which is simply a fancy name of saying there's herniated sublingual gland into the submandibular space. And then sometimes that can be palpated as an abnormality. All right, so somebody did ask for the prior question, does the distinction between peritonsillar abscess and suppurative retropharyngeal lymphadenitis matter clinically? Well, as with many things in neuroradiology as well as head and neck radiology, location is everything. And so that distinction does matter in terms of guidance for the otolaryngologist as to what kind of surgery they're going to do. And depending on the patient, sometimes peritonsillar abscesses could be drained at the bedside, IND, through the mouth. Depends on, if the child is cooperative. But suppurative retropharyngeal lymphadenitis is often treated medically if the abscess is small enough and monitored, and or if it's large enough, it would require a trip to the OR to incise and drain. And it's located, at a very different place of anatomy than the peritonsillar abscess. So that would give the ENT some guidance as to what kind of surgery they're planning. The next case is an 80-year-old with bleeding out their laryngectomy site. What is the source? Okay, the correct answer here is right common carotid artery. So this is an important entity to know for real life, called carotid blowout. And when someone has a history of cancer in the head and neck, and they're bleeding out either the side of their neck or through their mouth, or through, in this case, the laryngectomy site, what you're concerned about is that there's exposure of an artery that is, about to blow, and that can be life-threatening. And in these situations, it is imperative to examine the scan to look for any artery that is exposed to the outside world, either through the, internally or to the, skin surface. In this case, I gave you the history that was coming out of the laryngectomy site. So we're going to look at this kind of ulcerated tissue that is superior to the laryngectomy here to see if there's any arterial enhancement that comes close to that surface. And so pay attention to this right common carotid artery as we scroll up and down. There's an irregularity of that contour and kind of an out pouching of the common carotid artery as you're getting close to the surface of the airway, essentially. And so that represents a pseudoaneurysm, the right common carotid artery. Now, I gave you this case, and it's tricky to get it, in the span of 25, 30 seconds. Because there's all this kind of other distracting stuff here. There's some surgical clips there. There's the thyroid gland here, which is this hyperdense stuff on the left side, which many of you may have thought was contrast. But the abnormality here is pseudoaneurysmal dilatation of the right common carotid artery, projecting towards the luminal surface of the laryngectomy site here. And so that represented the site of the hemorrhage. In this case, this patient did go on to catheter angiography to interrogate that site and put a stent across it. During the catheter angiography, because of the high pressure injection, the fragile nature of that pseudoaneurysm, it did rupture. And so there was a lot of intraprocedural bleeding, but they did manage to get a control of it. Next case is a 75-year-old with neck swelling and difficulty breathing. Which of the following is the most likely diagnosis? Okay, the correct answer is diffuse large B-cell lymphoma, and I tried to make the question easier, not to have you choose between different types of malignancies. But the bottom line is that based on these images, you should be suspicious for a malignancy. We have this large mass in the right anterior and lateral lower neck that is kind of confluent with the right thyroid lobe, but also extending to the lateral neck in this kind of very nodular way, and that may be extension of the primary mass or additional kind of nodal metastases. Um, the other answers here are not correct. Benign multinodular goiter would have the appearance of kind of hyperdense thyroid tissue and kind of has the well circumscribed kind of shape to it. It would be larger than normal thyroid, but it would still kind of contain, some of the kind of shape characteristics of thyroid, whereas this is, unilateral and low enhancement abnormality and has kind of infiltrative borders into the lateral neck, and that would be suspicious for malignancy. And the things I would consider on the differential include lymphoma, as well as anaplastic thyroid carcinoma, and other malignancies with like kind of regional metastatic spread, such as from the airway or the larynx or something like that. But we didn't see any of that. And the other things that were distractors here are not correct. So transient perivascular inflammation of the carotid artery syndrome, or Tippich syndrome, would appear as a thickening of the wall of the carotid artery, but it would not be this thick. It would be like a couple millimeters thick. And then spontaneous cervical swelling syndrome is simply an edema of the fat of the lower neck, typically on the left side, hypothesized due to be leakage from the thoracic duct. Someone asked, was paraganglioma on the differential for this question? I'm not sure which question, but maybe it was the prior question. Paraganglioma would be hyper enhancing on contrast enhanced CT, and that would also not be as infiltrative and wouldn't be in my differential. Okay, the next case is a 25-year-old with swelling under the tongue, and we have axial T1 weighted image without contrast, axial T2 weighted image without fat suppression, a T1 coronal post-contrast image with fat suppression, and a coronal T2 weighted image with fat suppression. Okay, the correct answer is ranula, which 93% of you got correct. So the origin of the word ranula means little frog, and because these patients present with swelling underneath their tongue, kind of like some frogs have a swelling underneath their chin. And in this case, we have bilateral ranulae or ranulas, and the one on the right is so large, it is extending over the posterior edge of the mylohyoid muscle and diving into the submandibular space. So that's called a plunging ranula or a diving ranula. So what these represent are salivary retention cysts of the sublingual space, and in some cases it can be quite proteinaceous, which is why it has this intrinsic T1 hyperintensity. On other cases, on the left, we see the left side collection is not intrinsically T1 hyperintense, so they can be of different characteristics. But the key is that they're not like contrast enhancing masses, and they're located not at midline, and they're located in the sublingual space primarily, but they can dive into the submandibular space. And so when you see a cystic lesion of the floor of mouth that is lateralized, think ranula. Our next case is a 65-year-old with left neck lump and pain. What is the likely diagnosis? This is the third to last question. Okay, the correct answer is HPV-related squamous cell carcinoma. So the imaging findings here are cystic or necrotic lymph nodes in the left level 2. There are 2 of them. And in addition, if you see, metastatic appearing lymph nodes at level 2, the first place to look is really the oropharynx, and that would be the most common primary site. And indeed, we see a contrast-enhancing lesion on the left base of tongue that likely represents the patient's primary malignancy. And so oropharyngeal cancers these days in the United States, with the decline of smoking and alcohol-related cancers, HPV-related squamous cell carcinoma of the oropharynx actually is the kind of predominant type in the oropharynx now, especially in patients without a history of smoking or alcohol use. And so this is a virally mediated disease. HPV-related oropharyngeal squamous cell carcinoma would be the most likely answer. Certainly, this is not pathognomonic by imaging, but is most likely and would require appropriate, histological workup. Less common in this country and less common in this location would be EBV-related nasopharyngeal carcinoma. I'm not showing you the nasopharynx, I'm showing you the oropharynx, the base of tongue. So that would be oropharyngeal carcinoma, which is predominantly HPV-related. A 55-year-old with a history of oropharyngeal cancer and external carotid artery embolization, now presenting with recurrent bleeding from their mouth. Which site on this CTA represents active extravasation? I have labeled A, B, C, and D at the level of the oropharynx, a CT angiogram, composite image, a virtual non-contrast image based off the dual energy analysis, and an iodine-only map. So this is really a physics question asking about your interpretation of dual energy CT. So on the composite image, I've really pointed out 4 different hyperdense things. I told you they have a history of external carotid artery embolization and cancer. And so your options are, is it a normal vascular structure? Is it contrast extravasation? Is it calcification? Or is it embolic material? And so on the virtual non-contrast, we see what was a high density has dropped out over here at A. And so this is likely contrast. We see that D has also dropped out, but this is a location that it's normal and round. And this is actually the internal carotid artery. So that's a normal vascular structure. So that's not the correct answer here. You just have to know what is the most likely bleeding source. Well, it's the stuff that's at the surface of the pharynx, and not this stuff that is very deep and very regular in appearance. It's this stuff that's irregular and near the surface. This, if I showed you more images, you would clearly recognize as a normal vascular structure, and that's the internal carotid artery. Some of you chose C. So C here is bright on the composite image, bright on the virtual non-contrast, and also bright on the iodine map. But this represents calcium. So this is a calcified lymph node that has dystrophic calcification in this region. The reason why it's calcification and not contrast is that we see it as density on the virtual non-contrast image. And this comes to a pitfall of interpreting these images. If you only look at the iodine map and think everything that's bright on the iodine map is iodine, that would be incorrect. Because calcium is also bright on the iodine map. You see the bones are bright as well on the iodine map. And so too is calcification of soft tissue structures. That remains bright. So it's not just iodine that is bright on an iodine map. Remember that, okay? So look at your virtual non-contrast that would exclude iodine to look for things that have dropped out that would be extravasation. So A is a pool of contrast in the oropharynx. This is due to bleeding from an external carotid artery branch after embolization coils, which are in location B, had migrated from its prior course towards the surface of the oropharynx here. Okay, I think this may be the final question. 35-year-old with the left neck mass, what is the likely diagnosis? I'm showing you T1 pre-contrast image, a T1 post-contrast image with fat suppression, a T2 image without fat suppression, and an ADC map with the ROI showing 1900 times 10 to the minus 6 millimeters squared per second average ADC in this ROI. Okay, very good. A plurality of you chose the correct answer, which is schwannoma, and specifically, this is in a location that would be typical of a sympathetic chain schwannoma. The key to getting this answer is twofold. Number one, recognizing the location of this. It is not in the parotid gland, which is more anterior and lateral to the sternocleidomastoid muscle. And so the answer is not a pleomorphic adenoma. It is also not related to the submandibular gland, which is anterior to these vessels. Rather, this mass is posterior to the internal carotid artery, external carotid artery, and somewhere else would be the face jugular vein. And so the location that is posterior to these carotid sheath vessels and deep to the sternocleidomastoid would essentially exclude pleomorphic adenoma from your differential diagnosis. Some of you chose carotid body paraganglioma. So carotid body paraganglioma sits at the notch in between the external carotid and internal carotid. So at the crotch of the carotid bifurcation, and that mass would then splay apart the flovoids here represented on the T2 weighted image that represent the external carotid and the internal carotid arteries. So a carotid body paraganglioma would splay these flovoids apart, whereas this mass is anteriorly displacing both of them. And so that pattern of displacement would be typical of a lesion such as a sympathetic chain schwannoma. In the differential would be a vagal schwannoma, and that's it gets a little bit more complicated as to how to distinguish that from a sympathetic chain schwannoma. So I didn't offer that as a distractor, but basically a sympathetic chain schwannoma would anteriorly displace the jugular as well, whereas a vagal schwannoma would kind of splay apart the ICA and the jugular vein. So the high ADC also supports a schwannoma, as a schwannoma tends to have very high ADC. And other features that would support schwannoma over paraganglioma is that we don't see flovoids within this mass that you would see in a paraganglioma. All right, so the leaderboard is led by Radius, Guest 871, and D. Thank you guys so much for participating. Before you leave, please fill out the feedback form, and thanks for spending a little bit more than an hour of your Saturday afternoon learning head and neck radiology with us.
Thank you so much, Dr. Deng. We had a question. I asked them to leave for the end of the session. You had a case on lymphoma, a case of a 60-year-old man with eye pain and swelling. And the question was, is that black turbinate sign in the case? Yes. Yeah, it was the case. You are muted, Dr. Deng.
Yeah, great question. So black turbinate sign is a sign of an acute invasive fungal sinusitis where you see a turbinate not enhanced. And in this case, the only image that I reliably show the turbinates are on this image. And on the left, we see the inferior turbinate here that is enhancing. I for some reason, I do not see the right turbinate, and that's because it was resected. This is not non-enhancing turbinate. This is secretions within the right nasal cavity. So the appearance of this is slightly different from a non-enhancing turbinate. This is just fluid clogging up the right nasal cavity. So this patient had a prior history of sinonasal surgery because this image is actually taken from the time of a disease recurrence for them. So they've had prior sinonasal surgery, so inferior turbinate resection. So that I'm not showing you a black turbinate here.
And the other question was, does high diffusivity mean opposite of diffusion restriction?
Yes, so high diffusivity means high diffusion, which means the opposite of diffusion restriction, which is low diffusion. So yes.
And the last question is, can you please review the necrotizing otitis externa case?
Yes, absolutely. It's one of my favorite diagnoses because it is so commonly missed. and it's important to catch if you're ever reading these kinds of studies out in the community. So the typical clinical scenario for these patients is that they're an older adult who may have diabetes and they've had otalgia or a clinical ear infection for some time. And the CT is obtained because the otolaryngologist wants to basically exclude bone erosion that would point either to necrotizing otitis externa or coalescent mastoiditis. But the location of pain may be slightly different and clinically distinguishable. So the findings in necrotizing otitis externa is, number one, the soft tissue findings are thickening of the EAC soft tissues. They're completely occluding the EAC in this case. But that's not specific for necrotizing otitis externa. That's just a sign of otitis externa, which is an EAC kind of soft tissue infection. Necrotizing otitis externa, also known as malignant otitis externa, is characterized radiologically by bone erosion of the external auditory canal. So the normal EAC bone should go all the way over here, whereas here on the right side, that bone is truncated. And it is easiest to identify that if you have a prior, you can make the comparison. But here, just as well, we can see on the normal side, there's a long plate of bone that's called a tympanic plate, and this forms the anterior wall of the external auditory canal, but the lateral aspect of it is completely gone in this case. And on the coronal images, we see the floor of the EAC is also truncated. So normally the floor of the EAC, the bony EAC, should go all the way over here so that you can draw a line of the temporal bone cortex down here and meet kind of the lateral edge of the floor of the bony EAC over here. But all of this bone is gone. And so these findings are considered, due to erosion from their otitis externa. And in addition, the sequelae that develops in these cases is that the infection, once it has eroded through the bone, will then spread through the fascial planes underneath the temporal bone below the skull base and proceed medially, and will infect the bone more medially. And that's when you can see subtle erosions of the inferior surface of the petrous temporal bone. So here we have lost the nice cortex over here. And I tried to give you a very symmetric image so you know what the normal cortex looks like. Sometimes bone here is not really well mineralized. So you have to use symmetry to your advantage to know what is normal looking cortex and what is not. And this is early erosion of the medial part of the inferior surface of the petrous temporal bone due to skull base osteomyelitis that has complicated their necrotizing otitis externa.
Thank you so much, Dr. Deng. This is the end of the session.